It's really with great pleasure that I introduce Dr. Paul Sachs. Dr. Sachs is the clinical director of infectious disease at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. He trained at Harvard and then did his residency in infectious disease fellowship at Brigham and Mass General Hospital. He teaches locally, nationally, and internationally on HIV and infectious disease, and now most recently on COVID. And if his name or his face look familiar to you, it's because he's been on the news, he's been in the newspapers, and he's really one of our most trusted experts since the pandemic. And one of the things that's really special about Dr. Sachs is that he not only is an expert on the technical nitty-gritty, but he is able to translate that expertise and make sense of the science for the rest of us. So Dr. Sachs, thank you so much for joining us. And I want to welcome everyone in the audience. We have received lots of questions already, but I would encourage you to please put more questions if you have them into the Q&A. And Dr. Kelly Hedgepeth and Dr. Bilchik and I are going to take turns asking questions.
And I just thank you for that really nice introduction, and say that I recall Dr. Lown very fondly from when I was a resident at the Brigham. He was still a clinical presence. And one of the great things about him was that he always viewed the patient as a human being. And that was like the primary lesson that he was teaching us all the time. You know, he was brilliant scientifically and clinically, but he really was a human being first. And that's very important for all doctors.
So important. And even though his legacy might include the Nobel Peace Prize and include the defibrillator and the CCU, I think his greatest legacy is what he's passed on to his fellows like Dr. Bilchik and Dr. Ravid and Dr. Blad and all his trainees about, seeing the patient as a human being and not just a set of symptoms. Totally agree. So switching gears, Paul, I would like to ask you a little bit first about the vaccine. And perhaps we can start with, if you could explain to us, we know about the Moderna and the Pfizer vaccines, that they're 2 doses, and then a new vaccine coming out from J&J that's going to be a single dose. Can you briefly compare the differences between the Moderna, Pfizer, and the J&J, and whether you think there's an advantage or disadvantage to either of those?
The first thing I should say is that in a period of vaccine supply issues, the best vaccine to take right now is the one that is offered to you, because we don't have enough vaccines for everybody. And so in this period, by all means, if someone's offering you a vaccine, whether it's the Pfizer or Moderna or the soon to be available J&J, go ahead and take it. But they differ quite fundamentally in how they work. The Pfizer and the Moderna vaccines are messenger RNA vaccines that are 2 doses, and they stimulate a very brisk immune response. And we know from the clinical trials that they're extremely effective in preventing disease. And that's very, very, very exciting. J&J is using a completely different approach. It's taking a virus that's called adenovirus, and it's a virus that doesn't reproduce in human beings, and it's using that virus to get the same antigen into you that the Moderna and the Pfizer vaccine are doing, and it stimulates a response after just 1 dose. Now, it doesn't appear to be quite as effective when you look at the raw numbers compared to Pfizer and Moderna. On the other hand, it did very, very well protect against severe disease. And as a result, the most important thing is really to convert this infection into something that's much more like just the common cold or the flu. And the Johnson & Johnson vaccine clearly does that. So even though it may not on paper look quite as effective, I would say go ahead and get that one if it becomes available to you. And there's no saying that in the future, if necessary, you could go ahead and get the other vaccines.
Okay, all right. So they're totally different technologies. And it may be that down the road, they decide that Johnson & Johnson needs a booster too, right? So there's nothing magic about 1 dose or 2 doses.
Well, one nice thing about the data we have for the Johnson & Johnson vaccine is that it's quite effective. I mean, it was in the 70 to 80% range. And if you had told me, say in June of 2020, that we would have a 70 to 80% effective COVID vaccine with 1 dose, I would have been, that's incredible. But the fact that Moderna and Pfizer came out with 95% effective vaccines sort of set the bar so high, it makes everything else seem not as good by comparison. But all of them prevent against severe disease, and that's really exciting.
Great. Now, as an infectious disease doctor, what does it mean that it prevents against severe disease? So you're still able to get it, but it keeps it from progressing?
So it actually, I think people, it's kind of a curiously difficult to communicate this, but the vaccines definitely prevent against severe disease. They also probably prevent infection, period, so that fewer people actually get infection at all. But it's much, much harder to measure that because that requires that people do periodic PCRs even when they have no symptoms. We're starting to see evidence, though, that the vaccines not only prevent severe disease, but they also prevent infection, and they also lead to, if a person gets the infection, they have less virus in them. So you're probably aware the largest per capita success so far in the COVID vaccines is in Israel, and they've collected data on people who've been vaccinated, and they clearly show that those people have lower amounts of virus in them if they get COVID than people who have not been vaccinated. And lower amounts of virus translates in being less contagious. So even though we can't say with ironclad proof the vaccine is going to prevent infection and prevent transmission, I'm pretty sure it will. It'll reduce the risk of transmission. If not, it won't eliminate it, but it'll reduce it substantially.
Okay, so that's a really important question. Is the next one is, are these viruses going to prevent transmission? So maybe say a little more about that, because people are asking, once I get the virus, can I fly in an airplane? Can I hug my grandchildren? Can they hug me?
So once you get the vaccine, you're protected against getting severe disease, which is really the key thing. And so that means that if you want to, see your grandchild and hug your grandchild, you can. I mean, even though all of the public messaging is we still need to wear masks and do social distancing, that really applies more to public settings and crowds and high risk getting together during a time when there's still a lot of COVID in the community. But the fact is that being protected against severe disease allows you to interact with others in a way, especially family and friends, in a small group setting that before you couldn't do. And I want to emphasize that, because I think that some of the vaccine hesitancy I hear from people is based on the fact that they say, oh, I'm going to get the vaccine and nothing's going to change for me. Well, that isn't true. In fact, things are going to change. And I think we need to get that message out.
That's a really important message, because even though we might still wear masks when we go to the Red Sox game, we don't necessarily need to.
Or the grocery store. And the other thing is that remember that there's still the huge proportion of the population have not been vaccinated. So that's why we still, when we're in public right now, while there's still a lot of COVID being transmitted in the community, we still need to wear masks and maintain social distancing. But I hope that will change over time. Right now, though, and the best use of the vaccine would be for those small groups and those key interactions you need to have.
Perfect. The timing of the second vaccine. So a lot of our patients have been able to get the first vaccine.
Right.
Some of them as a driver or accompaniment to someone who was at high risk. And so some of them have been told, we can't guarantee the second dose will be exactly in 3 or 4 weeks. It might be 6 weeks or 7 weeks. Is that going to be a problem if the second dose is delayed?
It really won't be a problem. In fact, worse would be getting the vaccine second dose too early, because really what the way the immune system works with these mRNA vaccines is that the first vaccine primes the immune system, and then the second vaccine boosts it. So you get this big rise in antibodies that are very, very protective. And there's no reason to think that waiting 5 weeks instead of 3 or 6 weeks instead of 4 is going to be an issue. Now, we don't know what if you wait 6 months, would it still be the same? We actually don't know because we don't have that experience yet, but not waiting 6 weeks won't matter.
Okay, good. Now, what's your experience been and the world experience with the second dose? So a lot of people have heard the first dose is pretty easy to deal with. The second one, people get sicker. Is that true?
Yes, there are more side effects with the second vaccine. I'll give you my own personal experience. I'm lucky enough to live in Brookline, and I walk to the hospital. It's about a 1.8 mile walk, approximately. And I got my second vaccine dose, and I was walking home that evening. And I was like, ooh, I don't think I'm going to make it,
Felt
but
like
I
a
did.
long walk.
I was extremely fatigued. This is actually the day after, not the day of the vaccine, the day after. And it was just a feeling of kind of, I knew that I wasn't feeling quite right. I had a slight headache. I was very tired. I had a little difficulty concentrating. So that night I went to sleep early, and the next day I felt totally fine. It does mean that your immune system is responding to the vaccine. And I will say also that younger people are more likely to get severe side effects than older people. But overall, it's a trade-off I'd take any day of the week. The side effects from the vaccine were a day in duration, whereas COVID-19, as you know, can be life-threatening and lead to lots of permanent consequences.
Do you think that if someone doesn't get those side effects, they should worry that their immune system wasn't acting?
Yeah, exactly. So I've had that question so many times. I'm glad you asked it. So it did appear that everyone was protected not everyone, the vaccines were 95% effective, and that included people who had few or minimal side effects from the vaccine. So I was actually asked this question by a very intelligent and accomplished cardiologist at Brigham and Women's Hospital. He says, I had no side effects from my second vaccine. I'm worried it didn't work. Do you think possibly I got a dud, or you think I should get a third shot? Or are there any tests we can do to make sure it worked? And really, I would just say that the clinical trials data are so reassuring that I would not do any of those things.
Okay. Because people worry that with the regular flu shot, we have the high dose for older patients and the lower dose for younger patients, because their immune system as older people get older is less vigorous. But that has not borne out.
Well, it's interesting. First, let's just comment what we mean by old. Older is like anyone 10 years older than I am is the definition of old. But I will say that encouragingly, in these clinical trials, they made sure to enroll a significant fraction of people over the age of 55. And the reason they used that age cutoff is because, remember, COVID-19 really does strike older people much more harshly than younger people. And so they had individuals in their 60s and 70s and 80s in these studies. What they did not have in the studies were very frail people. So for example, if you go to a nursing home and you say, is this population represented in the clinical trials? The answer is no. And it is possible that the very frail elderly people would not respond as well to the vaccine, but we just have to see, because we've just started really the process of vaccinating them.
Okay. In pediatrics, they tell moms not to give their kids Advil, aspirin after a vaccine because it might blunt the immune response and blunt the fever that's very helpful. Is that true with this shot? Should we not take Advil?
Well, it's recommended that you not take it ahead of time. And that is because of the theoretical blocking of the immune response. But once those symptoms start to kick in, if you're a person who gets your second COVID vaccine and you have a fever of 101 and a terrible headache, taking a dose of Tylenol or ibuprofen is not going to cause any problems.
Okay, good. Because it's already out of the barn, right?
Kicked in. Yep.
Okay, perfect. Excellent. Now, is there a difference between having natural immunity from having had COVID versus having had the vaccine? Is one better than another? And if so, if the vaccine is better, what should the timing be after you get sick to get the vaccine?
So there are really two questions in there. So let me take the first one first.
Okay.
So the natural immunity from COVID-19 is mostly protective of getting it again. Fortunately, there are people who get reinfection, but it so far is pretty uncommon. And whether that's better or different or worse than the vaccine-related immunity is unclear. I will say there are examples in infectious disease where the vaccine-induced immunity is actually stronger than natural infection. And the example that's most commonly cited is with human papillomavirus, which is a vaccine we give to prevent cervical cancer. And it is clearly more effective to get vaccinated against human papillomavirus than it is from natural exposure, which doesn't confer much natural immunity at all. So sometimes people assume that natural immunity must be better, but we don't actually know that. And in fact, the antibody levels that are generated from the vaccine are as high as we see in people who've been immunized. So,
great. And how about protection against these new variants? So there's the British variant, which seems pretty similar to the original, and then the South African Brazilian variant that may be quite a bit different. Should natural immunity from having had COVID protect against those? And do you think the vaccine, either of the vaccines, would protect against those?
So the data on the variants are emerging and on an almost day-to-day basis. And as you alluded to, the 1117 variant that is originated or is first discovered in Britain has a higher level of contagiousness, but does seem to be neutralized by the vaccine-induced immunity just as well as the original variants. And then the other ones you mentioned, somewhat less so, but it still appears that most people would generate enough antibody response to still be protected, which is good news. Nonetheless, I'm aware that the companies making these vaccines are going to retool the antigens used in them to try to make them more broadly protective. So that is something that might be coming as boosters in the future. It depends. It really does depend. There is this one sort of natural concerning story from Manaus in Brazil, where a second wave of infection came into that community with the new variant, and even people who'd had COVID before didn't seem to be protected. Still not exactly sure what's going on there. That is a story that's unfolding, but that's we'll have to see.
Okay, and sort of really a day-to-day unfolding, isn't it? But once they get the vaccine technology, to alter it to include these new variants isn't as much of a big deal as making the vaccine in the first place, right?
Well, no, I mean, exactly. I mean, I think the real brilliant insight of being able to develop mRNA vaccines is phenomenal. I mean, I can tell you that vaccine researchers have been working on mRNA vaccines for 15, 20 years and succeeded, thank goodness, this year and succeeded in record time. So it's not something that just happened overnight. They've been working on it for a while, and really much more difficult is to get a vaccine that works than get one that is tuned just right for these variants. And there are other vaccines in development besides the three that we've discussed so far. There's one that a company called Novavax has developed that uses a nanoparticle antigen with an adjuvant. So it's a kind of a more like the shingles vaccine. And that is also they said that they're able to quickly change that one as well. So that one's the US data on that one are due in the next couple of months, and then we'll probably be able to get that one also.
Wow, amazing. All right, I'm going to ask one more sort of speculative question, then I'm going to turn it over to Brian Vilchik. But tell us what you think the next 3 to 6 months is going to look like in this country regarding the pandemic. What's your prediction?
So, as you probably know, the case numbers are dropping, and they're dropping everywhere, which is great news because things were really bad in the United States in December and January. And people are trying to explain in all kinds of ways. They say it's the holidays. They say that people got pandemic fatigue. And that is maybe partial explanation. I think also one thing that everybody, especially pediatricians, know, and I'm married to a pediatrician, is that viruses are very seasonal. And when you say seasonal, it means that it doesn't mean that they stick precisely to a season. It means that they have certain times of year where they become more common. And coronaviruses, the other ones, not the one that we're talking about now, but the other coronaviruses that cause a common cold and occasionally cause pneumonia, but aren't that worrisome, they're quite seasonal also. And it really, in hindsight, shouldn't surprise us that this would happen. In fact, almost all of us predicted it was going to happen. And what happened this time, though, is it happened absolutely everywhere. So that's why the case numbers were so massive nationally. But then the same thing happens at the opposite end of the season. And so even though it's still winter, obviously, I mean, it's cold and it's, icy and snowy, that doesn't mean it sticks with you the whole season. The same would happen with the flu season. There's peaks within winter. And that's, I think, part of the reason why the case numbers are dropping so much. Part of it also is our behaviors, which have tightened up. But I think there is a certain degree of effect of natural immunity and probably to a small degree the vaccines. So the case numbers are dropping. Great. So what's going to happen in the next few months? Well, we have to be like laser focused as a country in getting as many people vaccinated as possible, because this is giving us a window of opportunity to gain control of the pandemic. And I don't want us to blow it. So, it really means mobilizing in a way that's national and not just at a state and local level, but a national level. And I'm really hopeful that the Biden administration will pull out all stops to make it a national effort.
Great. And it looks like that's the direction they're heading.
Yes, but they gotta be really focused on this.
And the governors too, right? It's not just Biden.
Yes, but the idea that you would give these vaccines to the states and just let them figure it out. I mean, it takes enormous resources to vaccinate hundreds of millions of people, which is what we're talking about. And that's what we have to do. I mean, and we got to do it before the seasons turn again. So anyway, I think that things are going to be way better this summer than last summer. And one way we'll know is that we'll look at our hospitalization numbers. So, back in, just to use the Brigham as an example, because it's where we work, back in the spring, we got up to nearly 200 people in the hospital with COVID. And then over the summer, it was down under 10. And, everyone's like going, wow, maybe it won't come back, but it came back and we went up over 100 again. So what we want is to avoid that ever happening again. We want there to be, just a few people here and there who get COVID. And once that happens, then we can start actually getting much more back to normal life.
Cannot wait. All right, yes. Brian, do you want to jump in with some questions?
Sure. Thank you so much, Paul. And it's such a pleasure to have you with us at the Lown Group, because we've known you for many, many years. Anyone who's worked at the Brigham has certainly curbside consulted you, and there are some people who know a lot about specific topics, but you're one of those people who knows a lot about a lot of things, and it's such a pleasure.
Baseball too.
Baseball, music, poker, and one of the things I wanted to touch on, and I think it's been a very frustrating year being in healthcare and seeing, the information and misinformation around COVID, and how important it is now to really target the therapies and the vaccines that we have. And I think the mysteries of being in the hospital and diagnosis and everything, that we all feel a lot more comfortable and confident. So I just wanted to reinforce what you said about we have to be laser focused as best as we can as a community, not just patients, but as a medical community, in getting as many vaccines into as many people and as quickly as possible. I had a couple of specific questions, and the one, how soon after someone has had COVID can they be vaccinated? And then there are a couple of people who have asked questions about having had the first vaccine and then actually testing positive between vaccine doses. Do you delay the next dose after that vaccine? Sure. And then I'll ask you another question after that.
Yeah, so the vaccines became available right as case numbers were peaking. And so there were quite a few people who probably were in the incubation period when they got their first dose, and then they got COVID between the two doses. And there were people also who got COVID just like a month or so before they got their first dose. So the general recommendation is that once a person has completely recovered from COVID-19, they can either get the vaccine whenever they want, or they can wait 90 days. And why 90 days? Well, it turns out that reinfection before that 90-day period is incredibly rare. So there doesn't seem to be any rush to get vaccinated because you're protected by your own natural immunity. The other thing just to mention about people who've had COVID before, and one of our professors here at Harvard, he's a pulmonologist named Ed Nardell, was very open about his experience. He got COVID last spring, and then he got his first dose of his vaccine just recently and had a really severe reaction, not severe, like life-threatening, but he had high fevers, shaking chills. He said it felt like he had COVID all over again. And he then got better the next day. But it turns out people who've had COVID before, their immune system has already been primed to react to the vaccines. And their first vaccine feels a lot like most people's second vaccine. I should just tell you also that he then got his second vaccine and had, not much of a reaction at all. So, getting a reaction like that on your first vaccine could indicate that you had COVID before, or just something to be aware of if you've had COVID and you recovered from it. So 90 days is a safe time to wait. I've known people who've decided to wait the 90 days. I've known other people who didn't, but there's no hard and fast rule, one or the other.
And in fact, in France, they suggested, based on a study, that once you've had COVID, one vaccination may be enough.
Yes. There is certainly antibody levels after that first vaccine for people who've had COVID are just as high as people who get 2 vaccines. That theoretically means they don't need a second vaccine, but we don't actually know that. And so in the United States, we're kind of sticking with the two-dose strategy, even for people who've had COVID before.
And, just as far as patient anxiety, about getting the vaccine and being, those people are in those holes of not being eligible yet. I mean, there's been so much challenge for those patients who have been in the eligible group to get appointments and a lot of anxiety in that regard. But those people who are waiting, and I guess the question is, if those people are waiting, and you mentioned this before, and if the Moderna and Pfizer aren't available, but the Johnson & Johnson is, which is one shot, from a public health perspective, obviously we want to get anyone vaccinated with whatever is effective and available. But what are you going to say to your patients who say, I'm just going to wait it out till that Pfizer is available?
Well, I mean, unfortunately, that waiting it out could mean, depending on what you're doing in your life, could mean getting exposed to and contracting COVID-19. And 75% effective in preventing disease and 100% effective in preventing severe disease. That's the Johnson & Johnson vaccine. That's pretty good. So I would take that one if you've got it available. I mean, I know that if you have all 3 laid out in front of you, you would take the 95% versus the 75%. But that might not be an option we have right away. I think we are. By the way, I do feel optimistic that we'll have enough vaccine so that anyone can get immunized sometime this summer, maybe even as early as late spring.
And I have to say, just once the vaccine was given, and those of us who were fortunate enough to get it already, it was a little bit, there was a lot of apprehension and anticipation. It was a little anticlimactic after you've got the vaccine because, the world didn't change suddenly. Things didn't suddenly open up, but there is a sense of security and reassurance. And, certainly from from a physician perspective, we feel a little safer, but we're all doing the same things. We're being just as cautious and conscientious as we have been. But it did feel, until we really, all of us, see those numbers change, I think we're all going to have that little bit of hesitancy.
Sure, but again, the Israel and Pfizer struck a deal to get so many vaccines to that country, and what they said apparently is in the deal was that you need to collect very careful data. And so we've gotten really exceptionally good real world data from Israel's experience, and the the effectiveness of the vaccine in Israel among people over 65 is between 90 and 95%, which is outstanding and better than anyone could have anticipated. So, and hospitalizations in that age group have plummeted, and they're actually experienced quite a terrible surge so recently. So to see this happen so quickly in that country is a real testament to the effectiveness of the vaccines and gives us something to aspire to.
Yeah, that's great. And yesterday I was traveling, and the airlines already have said, obviously everyone needs to be masked all the time, even if you've had a COVID-19 vaccine or a prior infection. And then the other piece to that, which was a little reassuring, is that the quarantine period after travel has been lifted, which is also a really
For those who've
nice.
had the vaccine.
Yes, those people who have had the vaccine. Sorry.
Yeah.
Absolutely. So again, thank you so much. I know there's a lot more questions and a lot of people who want to chime in.
Sure, I'll jump in. There seems to be ongoing questions, Dr. Sachs, just about the viral shedding after you have a vaccine, which I know you've said. So maybe you just want to say it again about how families can approach this.
So if you have people in your family who've been vaccinated and you have not been vaccinated, give me a specifics. Be a little more precise.
Well, I think most of our patients are in the range where they're really concerned that they're going to have severe disease, right, or exposure to COVID and be really sick. So if they've been vaccinated and then maybe are exposed to their grandchildren or to family members that haven't been vaccinated, what is that risk, and how can we, not on a population scale, but on an individual family scale, maybe be living a little differently?
So, right now, with still a fair amount of COVID transmission in the community, we can't 100% guarantee that someone who comes to your house is COVID-free. You could, though, certainly feel much safer by having had the vaccine and then have your family member visit than before. And so the reason why I mention that is because people have been completely isolated from their families now for months, some going on nearly a year. And that is actually a real problem, I think. And our society we need to acknowledge that these vaccines do prevent severe disease. And that's the most important thing we can say. So I would just argue that small gatherings are going to be a liberating feeling. I'm not saying having a party with 200 people. I'm saying, get together with your grandchildren, see your grandchildren. So.
And I think that will alleviate a lot of the stress that we all are feeling from this isolation. So it's happy to hear that there's maybe some light at the end of the dark tunnel of this year.
I thought you were asking about whether getting the vaccine makes you less likely to shed the virus to others. And the answer is yes, it does. It doesn't eliminate the risk of your doing that, but it reduces the risk.
Yeah, so I didn't mean to confuse things. Those were two good answers to two different questions there. So I'm sorry I merged those together. And maybe while we're on this topic of families, you can tell us what you think we're going to expect for kids and for vaccinations.
Sure. They have started studying the COVID vaccines in older children and adolescents. It's likely that we'll have safety and efficacy data in them. I do want to underscore something, that lumping kids together in this is a mistake we all make, because the school age kids, like the elementary school age kids, really don't get very sick at all. Very uncommon, very, very uncommon. And so for them, it's mostly a very mild illness, and they don't appear even to be that contagious. Once you get into the teenage, young adult years, though, then those people are at somewhat higher risk of getting more severe disease and also become actually quite contagious. And so it's the young adults, that's college age kids, the kids in their 20s, very socially active, who have been probably the main drivers of the spread of the virus in most settings. And so the primary reason to vaccinate them is, I think, for infection control reasons more than anything else. Even though sure, I mean, there are exceptions, and especially if they have underlying medical problems or they're overweight or they have diabetes, et cetera. But most of the young adult infections are of no medical consequence except as transmission to others. And by vaccinating them, we could actually start breaking these chains. And it really takes, there are some real pessimists out there who don't think the vaccines will reduce transmission, but it takes, they will. They do in almost every infectious disease. So that's my goal, is to get the vaccines out to the 16 to 25-year-olds, because they're acting as viral spreaders.
Okay, good for us to know and to think about as we're approaching these family scenarios. Do you want to maybe say a few words about pregnant women and vaccination too, because that has also been
yes, absolutely. Pregnancy turns out to be a risk factor for severe COVID-19. And that's true of actually several respiratory infections, most famously influenza. And one of the reasons we strongly recommend that pregnant women get the flu shot is to protect them from getting the flu, because they could get so sick. Well, it's same is true about COVID-19. And the problem is that we don't have a lot of safety data on vaccinating pregnant women. So we need to have that conversation with women who are of childbearing potential, who are pregnant, who are breastfeeding, and say, we don't have a lot of safety data. There's not a lot of theoretical reason why the vaccines should be harmful to you or your baby. But we, what I do is I say, I do recommend it, but I would understand if you prefer to wait. And I think women, at least the ones I've talked to about it, have kind of varied. It seems like the healthcare providers have mostly opted to get the vaccine. And then women who are able to be more socially isolated during their pregnancy some have chosen not to. But I should just say the CDC, the OBGYN groups, they all agree that pregnant women should be offered the vaccine, and then have them make an educated decision.
Sorry, can I ask a question about masks? You know, we keep hearing single mask isn't enough, double. Should we be wearing N95s to the grocery store? What's your take on masks?
So the masks that clearly don't work very well are the thin cloth masks. So they're better than nothing, but they don't have very much protective barrier for either yourself or to protect others. The standard surgical masks that we are issued at the hospital every day are actually pretty good, especially if you're pretty good about forming them around your nose and tuck them in, et cetera, and make sure they're not drooping down. Can you create a system where you actually have more filtration? Of course you can, and that's what this recent CDC announcement was. If you put a cloth mask over a surgical mask, that has better filtration than just a surgical mask. And obviously, if you wear an N95 or an N95-like mask, that's even more filtration. Whether it's worth doing in all settings is a personal decision. I just would like people to wear a good quality mask. That's probably my first effort. And the bandana doesn't work.
In the ideal world, everyone would wear this type of a mask.
Yes, they would have one that's not droopy down.
That fits really tight.
Yeah.
And if you put a second layer to keep it more tightly sealed, even better.
Yep.
Some people don't have them. So, this is.
They're really, the surgical masks, fortunately, we're not in a situation of scarcity right now for surgical masks, and they're not very expensive. The N95 equivalents, or the KN95 or the KN94s, they cost about $1 to $2 per mask. So they are an investment, but some people feel like, I want to do everything I can. And so they invest in them, and they're readily available. One of the problems, of course, is counterfeits, but mostly the ones that you will be getting online are legit.
And can you reuse those?
So, reusing masks is a bad idea just because they can get bacterial infections in them. So your own bacteria are breathed through your mask. So, I mean, I'm not saying you can't reuse them. Like if you wear them for 20 minutes one day, you can wear it again the next day, but eventually those masks are going to get contaminated with your own bacteria. And, so that's why eventually you need to discard them.
And can you just throw it in the washing machine in a laundry bag and wash and dry it?
Not a synthetic mask, no.
Okay. I mean, I've done that with these. They don't fall apart until about the 5th wash, but maybe they lose some of their...
That's a good way of preserving the environment. I mean, one of the concerns with all of this PPE is how the disposable stuff has to be like, it's got to be terrible for environments.
Although it's compensated by the decreased carbon footprint of no airplane travel and
True.
less travel.
I have a question back to vaccines and so as a cardiovascular group and very interested in exercise and exercising outdoors versus exercising in the gyms, we've had fairly strict guidelines about what to do when people have had COVID and then getting back to an exercise program. From your kind of understanding, is there any concern about exercise after vaccine? Should one wait the 10 days? And then the next question is exercising outdoors and wearing a mask when one's running or jogging or doing other things, given the dispersion of being outdoors. I know some people just do it to be polite. It's really hard to exercise wearing a mask, and some of our patients we're encouraging to exercise at all costs to stay away from heart trouble. And so any comments about that?
So mask wearing outside when you're especially solitary exercise is really a kind of a show. It's kind of a way of showing that you support infection control in other settings. There is no evidence that outdoor solitary exercise requires mask wearing at all. And I kind of wish in a way that, if I could rewind the clock and say, what could we have done that would have made mask wearing less of a fraught issue for so much of the United States? I would have said back in March, April, I would have said, look, yes, wear masks indoors because it both prevents you spreading the virus to others and protects you. And just make that the kind of mantra, not you only need to wear a mask if you're a healthcare provider, or you only need to wear a mask if you're sick. That was the wrong message, because then we had to change it. But now we've gone sort of opposite extreme, and people get yelled at if they go jogging or biking and they're not wearing a mask. And to me, it's like that's silly, because that's not how the virus is spread. So, yeah. I mean, it's outdoors is so much safer than indoors. So encourage exercise in your patients outdoors. And if they can't wear a mask, as long as they're, decent distance away from someone and not talking right at somebody, they're not going to spread or catch the virus.
Yes, thank you. And any information about getting into the gym once people have been vaccinated? Should they be able to go back and exercise indoors?
Good point. Getting a vaccine does give you permission to do things that previously you might have thought was too dangerous. And that would include things like going to the gym, provided your gym is well ventilated and isn't overcrowded. Yes, I mean, that would be an activity that I would encourage.
The other issue is, everyone has serious COVID-19 fatigue, and there are so many people waiting in line for their number to be called. The people without any comorbid issues, people who are being exceptionally cautious. And as the numbers come down, perhaps people will feel a little bit freer to do other things. But what are you telling your patients or all the people, the hundreds of people who curbside you or ask you or email you about this? People aren't willing to or don't want to jump the line, so to speak. But what kind of psychological kind of reinforcement or are you giving people?
Well, I mean, I hate to use a baseball analogy because some people hate baseball, but we're kind of we're kind of in the seventh inning and the game's almost over. If we could just hang out a little longer and keep things safe, then we can do it. I mean, it's really, I'm looking forward to the time when you don't need to have me come on your Lown practice webinar to talk about a pandemic. I guarantee you, we are very much looking forward to things going back to something like what we had before. I don't think it's ever going to be quite the same, not for some time. I think we're going to be wearing masks for patient care for a long time, mostly because we don't want to spread anything to them. But the kind of severe restrictions people have on their activities now, especially our older patients. I mean, I have elderly parents, and they really have to be careful, and that's the way it's been now for nearly a year. So, but if we get to stick things out till the summer, we'd be in great shape. Don't go to restaurants. Take out restaurants. So I absolutely love food and eating out, and my mother was food critic, and so restaurants have always been part of my life, but not during this. Takeout.
What about outdoor restaurants?
Yeah. So again, outdoors is much safer. Outdoor restaurants, you really, especially if the case numbers go down the way they did this past summer. This past summer in Boston, there was, the test positivity for COVID testing was 1%. And the hospitals had very few COVID patients in them. And so if you combine low community spread with outdoor dining, that's safe. But not now.
And opening windows, if you have to eat indoors with family members, that really makes a big difference, doesn't it?
So ventilation is key. And there's a really brilliant Harvard School of Public Health environmental and epidemiologist named Joseph Allen, and he writes about this all the time. It's really an under-recognized infection control strategy is ventilation. Now, it is sometimes difficult in the middle of the New England winter to open the windows, but I can guarantee it that is definitely an important strategy. If you need to have people inside, open the windows. Yeah.
Great. Can you comment a little bit on the Massachusetts rollout and what maybe went right or wrong with that?
Okay. Next question.
Dr. Baker's not on the list, I checked.
Okay, good. So I'm going to say that part of it is lack of preparation. The vaccines, everybody knew that we had vaccines coming. And so the time to prepare for administering the vaccines is months before you get them. And I got the sense that was not really happening. And so then a few things transpired. I mean, I think that the hospitals were placed in the position of being leaders of vaccine distribution. Well, that's not something that hospitals have ever done before on a population scale. They've done it for their patients, but not for everyone. And then the other thing that happened is that I felt really bad for doctors and nurses and frontline workers who didn't have a connection to the hospitals because they were kind of left out initially. And then anyway, the whole thing. I think that the criteria are probably, some of them are some have said just use age as a criteria, and that's much simpler. So it's really a very difficult, I think preparation really would have been better months in advance.
Yeah, hopefully it'll start to smooth out, but I don't know.
Oh yes, yeah. When there's more supply, right?
What do you
think? There will be a time when we're actually doing the opposite. We're encouraging people to get their vaccine. So.
A lot of our patients are hoping that we'll get it here in the office, and we're hoping very strongly that we'll get the vaccine to administer to our patients in a controlled, calm, safe environment. And yet we have not been given doses from the state yet. So every Tuesday we request, and we've not yet gotten it. So patients are wondering, is it safe to go to Gillette, to Fenway, and to be potentially exposed to lots of other people who might have COVID, or should they wait it out? It's not really an answerable question, but is it safe?
Yeah, it is. It is safe. I haven't been to those settings myself, but it does appear that they're not crowding people into, poorly ventilated indoor spaces. I mean, that would be the kind of setting I'd be concerned. So yeah, I would recommend that they do seek out whatever opportunities they can, wherever they can, to get vaccinated.
Yeah. Okay.
There were a lot of advertisements in Craigslist for when the companion question came out, if you took a younger companion. And so younger people were offering hundreds of dollars to people over the age of 75. They would pick them up, they would pay them and take them to be vaccinated. And it was kind of an interesting and an intriguing kind of strategy of getting people to be vaccinated, but also, getting more people who are present in the vaccine sites vaccinated. But it caused a lot of upset for those people who were in the next phase, concerned about running out of vaccine.
Sure. No, I mean, there's going to be a lot of vaccine envy initially, but that should end soon. One thing I will say is that the stories that really make us appalled are when vaccine goes wasted. And so anytime you hear about that, because the demand is so high, to waste them just makes no sense at all. And there have been isolated examples around the country of when there's excess supply at the end of a vaccine day, just calling people in the neighborhood and say, who wants it, and come get it. We're all for that. I mean, there's nothing worse than wasting these very precious resources. So however they want to do it so that they're not wasting vaccine doses is okay by me. But I agree, there was a funny equation there for a while, where if you were a healthy 30-year-old with a car, you could get vaccinated as long as you brought someone who otherwise didn't have a companion.
A lot of questions about air travel. Is that safe-ish, and how can we make it as safe as possible?
So air travel, the ventilation of jets is actually much better than people even understood. And now we know that they're really well ventilated. One of the big problems with air travel is that the boarding process and the airports are not as well controlled. Once you're actually on the flight, there's a lot of air exchange, and there really have been surprisingly few transmission events on jets, amazingly few. I would expect them to be more. But what happens is that the boarding process and the airport itself are situations that are much less controllable. So, right now, most people are limiting the air travel. They're only traveling when absolutely necessary. And I understand, Brian, it was absolutely necessary for you. To start to think about another advantage of getting the vaccine is it gives you an ability to travel again for pleasure. Because, obviously with the goal of reducing severe infections, that was the risk of traveling before. And if you can reduce this risk of severe infections to nearly zero, then you can travel.
Paul, thank you. Is there any contraindication? We have some questions about people with autoimmune diseases and things like that. Anyone who you would say, I had even had a patient who had severe allergies to other injections and immunizations, who sat there with EpiPens, and none of them have had any reactions from an allergic reaction to the vaccines. So any contraindications?
So the only contraindication to getting a COVID vaccine is if you are known to be allergic to the adjuvants in there, the polyethylene glycol, or if you had a severe allergic reaction to your first vaccine, then you should not get your second one. If you have an allergy to medications, or allergy to pollen, or allergy to food, no matter how severe, you can get a COVID vaccine. You will tell that to the people who are giving you the vaccine, so that you can be observed for a little longer. A related question is, what about people who have autoimmune diseases like rheumatoid arthritis or lupus or inflammatory bowel disease, or they have other things that they're taking immunosuppressive medications for. People worry that the vaccine might worsen those underlying disease. But so far, there's not evidence that it would do that. And they're also worried about whether they should stop their immunosuppressive medications before getting the vaccine to improve their immune response. I should just say that the American College of Rheumatology just issued some guidances on how to manage immunosuppressive drugs before getting the vaccines. And I put a link to that in my frequently asked questions. It's in there. We've been updating that, by the way, on a pretty much daily basis. So we update on a daily basis, but then it gets formally published at the end of the week. So it's usually pretty up to date.
That's great. Okay, so we're going to post that New England Journal of Medicine frequently asked questions article on our website too.
Great.
And we'll update it too, because a lot of patients are asking how can they see that. So that'll be great. I have one more real question, and then I've got kind of a fun question from your brother. So stay tuned for that one. But the real question briefly is, what's the state of medications for COVID if you were to get sick? Do we have effective treatments? Did what Mr. Trump got, is that something people are getting? What's the deal?
So on the hospital side, we've made a lot of progress. For the really critically ill people, we use remdesivir and dexamethasone. What we lack are really easy to administer outpatient treatments. And there is this infusion of monoclonal antibodies that are available, but it's not so easy to get. I should say one of the things that makes it a little easier is that Quorum/CVS are involved in the distribution of monoclonal antibodies. And so they can, depending on where you live, come out to your house and give you the infusion. Alternatively, Mass General Brigham, the unit, can do about 5 patients a day during the week. There are other treatments being investigated. I mean, I think actually some of the data look promising for a drug called fluvoxamine, which is an antidepressant that has anti-inflammatory properties. There's a drug called ivermectin, which is an antiparasitic drug that might be useful for COVID-19. There's many people think taking vitamin D supplements helps prevent respiratory viral infections. I wouldn't take mega doses, but if you very little harm in taking a small supplement, a bunch of things, but no major transformative outpatient treatments yet.
Okay, perfect. All right, ready for the final question. Okay. What year did Ron Guidry go 25 wins and 3 losses and won the Cy Young Award?
1978.
Okay. Well, we told you that Dr. Sachs knew everything, and there's proof. Okay, so thank you so much. This was amazing. There are so many questions that we didn't get to, so I'm sorry to those of you who posted questions. They were wonderful questions. You've been a great audience. And thanks to all our panelists. And Paul, take care, stay safe, wear a mask.
Okay.
And hopefully we won't have to do this in 6 months, but
Hope so.
it's still going strong. Will you do a second version for us?
Of course.
Okay.
Thanks so much.
Bye, everybody.
Thank you.